Okay, so welcome everyone to the Jousse lecture. Maybe if someone could confirm if you hear us online, Lena, if you confirm.
Yep, we can hear you.
Awesome, great. I'll also just remind everyone that this session is going to be recorded. It's going to be posted online later. My name is Damian Manzone, so I'm part of one of the hosts for the Jousse lectures, and I'm a postdoctoral fellow here at KITE working with Dr. Jose Zarifa. Okay, so it's my pleasure to introduce Sukhvinder Kalsi-Ryan. So Dr. Kalsi-Ryan is a clinician scientist in the field of neurological rehab with a special interest in upper limb assessment, recovery, and neurorestoration. Her research is oriented to establishing methods to quantify neurological change after injury and studying neurorestorative methods to enhance and optimize function for those with neurological impairment. Her current role is as a PI of the Upper Extremity Neurorestorative Innovations Lab, where she uses evidence as a foundation for the implementation of new and existing clinical practices. She also serves as a member of the board of directors of the Canadian Physiotherapy Association, an editorial board member of Archives of Physical Medicine and Rehab, and is a member of the RECODE DCM steering committee. She provides academic teaching within the Neurological Resident Training, Rehabilitation Scientists Institute, Institute of Medical Sciences Physical Therapy programs at the University of Toronto, and she's the founder of her own company, which manufactures the GRASSP, which I'm sure a lot of us have used, and she herself acts as a consultant to device and pharmaceutical companies worldwide. So without further ado, here's Dr. Kalsi-Ryan. Should be okay.
Thank you, Damien, for that wonderful introduction. And I have to say that it's always really wonderful to speak at the Jousse lecture. And I'm very grateful to my colleagues who continue.
Let me just double check.
Wait.
Sorry. Okay, so back in there. Share again. And then turn your camera on again if you can.
Sorry. Is my camera on now? Can you see our
I
screen?
think turn your camera on again. Sorry, I don't know how it all switched off, to be honest with you.
Okay.
Let's see.
How's that, everyone? Can we see slides?
That looks great.
Okay, good. Okay, so as I was saying, it's always wonderful, and I'm also very grateful to my colleagues for having kept the Jousse lecture going for so many years. So today I'm going to talk a little bit about different perspectives, or actually what I would really like to focus on is the change in perspectives of recovery and restoration, particularly of the upper limb. Before I get started, I always like to acknowledge, I'll acknowledge all of the resources that have helped me get here, but also disclose all of my relationships. So of note, I will talk a little bit about the GRASSP, and as Damien mentioned, I'm the founder of my own company, which manufactures and distributes GRASSP. I'd also like to recognize all of the great scientists that I work with and have worked with over the years, all of the funding agencies that have supported my work, and also one of our collaborations, or our collaboration with the MSCI study or multi-center trial, and I'm Professor Kurt. So I wanted to talk today a little bit about the changing landscape of SCI trials. Now, I was just asking the year of birth of a couple of the people that are attending the lecture today. So I'm going to be going way back, but I think Heather's going to be with me on this one. Okay, great. So we're going to talk a little bit about the changing landscape of SCI trials, because that lends itself to telling you why we study the upper limb as much as we do today. So full disclaimer, we never looked at the upper limb. So back in the 90s, this was not something that we studied in the same way that we do today, particularly in spinal cord injury. And then we'll talk, I'm going to share some studies and some concepts and sort of some pivotal moments in the history of trials to show you why we've kind of evolved into studying upper extremity as much as we do. And then we can talk about what is it that we can offer today and what do we know today? So how should we be treating our patients? So how we treated them 30, almost 40 years ago, perhaps opportunities or interventions we offered has changed dramatically. So we now have a lot more evidence that we can tell you or share with you to determine how best to treat this population. So I'm going to go back to 92, and I do believe about 35 years ago was when we did our very first clinical trials in spinal cord injury, and these were called the SCIM studies. They were run between 1992 and 1998, and they enrolled hundreds of patients. However, it was just people with spinal cord injury, so the sample typically ran around 75% cervical and 25% thoracic. And they used a very general scale called the Asia examination at the time. And so they were just looking for their outcome, or their endpoint was a significant neurological change.
Keeps kicking us out. I'll jump up every time it happens, okay?
No problem. Are we sharing again? Okay. So the SCIM study, and of course, using a very gross motor scale, not seeing any change, they basically said these studies were, this was a failed study, or these were failed studies. Shortly thereafter, there were a set.
I'm sorry to interrupt you, but we can see your presentation view of your slides as opposed to the slides themselves.
Sorry, see. We're gonna try again. I think if we share just
That one.
this one.
Sorry.
No, it's okay. We're good?
We're good. Thanks, everybody. Okay, so getting on to, so after SCIM came a set of studies. One was called ProNeuron, the GRASSP trial. These were essentially, in one case, macrophages, and in one case, stem cells injected in the spinal cord. These were thoracic trials. They also failed. And largely due to the measurement that was used, so using just the Asian exam. So there were a couple of pivotal moments in this whole sort of history that I'm going to share with you. In 2006, Novartis actually put the start button on doing cervical trials and finding an upper extremity measure that was going to be used in these cervical trials. So this was really the start point of when the field started to move towards doing cervical injury as their study population. But how are they going to measure them? So that was what they had recognized, is that there wasn't really a sensitive tool to use. And so this really put a kickstart onto development of the GRASSP. So that was occurring alongside a continued trials. So in 2012, a few new drugs, RO inhibitors, etc., were put out into, FDA approval was accomplished. The first cervical trial was called the ASCENT trial, which was the company called Subio, and they closed their trial early because they were not seeing, I guess, in their interim analysis, seeing any change. However, they were also using the upper extremity motor score from the INSCI. And then came studies called the Asterius and stem cells trials, which were stem cell injections into cervical patients, where they did actually start to use the GRASSP, but extremely small samples, and they saw no benefit. And after 2016 or so, we saw this big launch in neuroregenerative, neuroprotective agents, etc. And we saw this onslaught of some clinical trials, all done in cervical spinal cord injury and acute. And in some cases, some trials using the GRASSP and some not. So we saw that there was this shift towards cervical injury, one, because it was a larger proportion of our SCI population, but also because of Kim Anderson's 2004 paper about what's really important for and meaningful for people. So in, I guess, unison or alongside or concurrently, we were also seeing rehab studies emerging. So there is a long history of locomotor training. I am not going to touch on that because today we're talking a little bit about the upper extremity. But locomotor and lower extremity training and rehab studies, I guess they started sooner or earlier and before we started really focusing on the upper extremity. But I'd say that it was the early 2000s when Adele Fielfolte's group is one of them, started doing some of these intensive rehab type trials, coupling it with some different types of neuromodulation, and really showing that it's possible to restore movement function, motor function after chronic spinal cord injury. We also have then a set of FES studies that were done by a number of different investigators, and I only mention Popovich because that is the lab that I'm currently in. However, there were many more around the world. In Switzerland, Inez Birch Parada, there's many people. But I'm just saying that there was then this surgence. Now, this surgence of upper extremity studies came, one, because Kim Anderson said it was important. People felt that there was a larger cervical SCI population, but there was another reason. Does anybody know what that third reason was, why we could do more upper extremity studies? Because we had measures. We had measures to measure the upper extremity, which we did not have prior to, I would say, about 2010. 2009 is when the GRASSP was made available. And after that, there came a number of different outcome measures. So now what we see is this launch into non-invasive stimulation studies, and we are now actively doing those. So started around 2015. And coupled with that, or done on their own, we see a lot of activity-based therapy studies, meaning lots of intensification of rehab and therapy. So we're seeing the field change. I got it. Are you seeing my slides? Oh, there? Okay. So we're seeing the field change. So I wanted to show you that the perspective went from any kind of spinal cord injury and do we get some recovery to very focused, very specific, and very much about upper extremity cervical population and how do we do this research and how do we do this research well. So we've gone from a shift from thoracic to cervical. Neuroprotection and regeneration are still very important elements that are looked at in acute trials. There's been a massive increase in rehab trials and rehab intervention development for the upper extremity. And we used to only see acute trials. So they would try and dose a drug early on, maybe within 24 hours, maybe within a couple days. But now we're seeing acute and chronic trials. We're going into, I think, our second chronic drug trial now. And so there's very many more opportunities for our patients. So 30 years ago, we thought we could only start when the injury occurred. Now we know we can continue to treat well after the injury and have an impact for our patients. And so the place that we probably need to go next is combinatorial trials. So putting a few things together, how about a drug and how about some exercise, and why don't we throw a little stimulation at them while we're doing this all. So this is really where our field needs to go, because what we do see is that people all make gains, very small gains from 2 or 3 different potential options, but what if we were able to put them together, and how do we move forward with that? So I was talking about these pivotal moments in spinal cord injury. So one of the first pivotal moments was when Novartis came to the community and said, listen, we need an upper extremity measure. And this will be the first in human cervical SCI drug trial. And the biggest gap was we don't have a sensitive tool. And that's actually one of those, there's a longer story behind the development of GRASSP, but that's where GRASSP came from. So we developed this tool, and within 3 years of putting this group together, we started using GRASSP in the community, and it's been a very slow uptake, but I would say it's probably one of the most successful uptakes in anything that I've learned about in spinal cord injury. But we didn't just have the GRASSP, we have the Toronto Rehab Hand Function Test. We have the GRASSP and Release Test, which was developed before GRASSP, but is now available. And we have the capabilities of upper extremity test. And if you look at any studies done today related to the upper extremity, you will see at least one of these tools used in that study. And this is really what's changed the field, is the culture of assessment, the culture of outcome measurement, and the ability to assess change after it occurs. The second pivotal moment in SCI trials was in 2011 when the Asia Association and the ISCOS Association came together and revamped the entire international standards of neurological classification for spinal cord injury. They completely standardized how the assessment was done, made it a much more reliable tool to use, because the belief is that This was used pre-2011, and many times trials would fail, and they truly believed it was because they weren't measuring things as well as they could have been. And so this streamlining really made a difference in the field. And the third pivotal moment in spinal cord injury trials was in 2016. And this is perhaps a little bit more of a quieter pivotal moment, but this was when they launched the whole concept of inclusive trials. So when you do a spinal cord injury trial back in 1990, you were only enrolling Asia A's, maybe B's, and you were looking for a change because those are the patients that would have an injury and not change naturally. And you apply a medication or a treatment and you would see change. And this happened for 2 or 3 decades before everyone realized this perhaps isn't the best way to do research because we don't see change. We don't see enough change. This was a pivotal moment because what we went from is only treating motor complete to treating all the patients. And that happened in 2016, and you're going to see that there's been a significant change in how we do our research these days. And so this concept they used, or this statistical analysis to design studies, was called unbiased recursive partitioning. Again, an entire lecture of its own, but it's an opportunity to expand your sample. So instead of enrolling just the Asia A's, you can enroll everybody with a spinal cord injury, minus a few that are already at a ceiling point. So in order to sort of demonstrate to you some of the findings we've had because of these changes in the field, I wanted to share some recent cervical spinal cord injury studies with you, just a few bits and pieces of some of the studies that have occurred over the last 10 to 15 years. So not one study, but a few studies was actually development of the GRASSP, but through this development of this tool, we actually garnered an awful lot of historical data. So we ran a cross-sectional study where we had we did a multinational study, and in the end we have a data set of 250 individuals measured one time with GRASSP, SCIM, INSCI, and sorry, GRASSP, SCIM, and INSCI to make things easy. A few other outcomes, but those are the ones that we analyzed. And then when we went on, share. Okay. Okay. All right. And then we also have historical longitudinal data. So looking at 182 patients over the course of a year, measured 4 times. So we have that data, and we can share with you a few things. So one of the things we can share with you is what is the recovery profile of somebody with motor complete and somebody with motor incomplete look like? And in this particular scenario, what you can see is that we do even have recovery in motor complete patients. However, it's modest in comparison to what happens to motor incomplete patients. And you can see, though, in both cases, it looks like both groups continue to have some recovery even at a year. But that depends, of course, on what you might be doing with them. So this is an example of what we can see. And we see that strength is probably one of the elements that changes the most in these populations. Strength is a great indicator of change. So what can we do with that data? How does it inform us today? So we kind of understand the recovery profile. We can always put that profile against a group of people that you're treating, so you don't have to have a control group. And we can tell you, does a treatment change exceed what the change is in a natural history curve? Or you can use the data to determine who's going to be in your study. So one of the things that we were able to do with this historical data set is power our studies better. Enrollment is a challenge in spinal cord injury studies. If you look at acute trials, often it's maybe 2 patients out of 10 are actually eligible to be in study, and there's a number of reasons why. What we did here was we took a sample of 89, I think it's 89 people from our historical longitudinal data set, and we applied upper extremity motor score of 28 or less to enrollment. So what that means is, out of those 89 patients, I would only take people with an upper extremity motor score of 28 or less at baseline, because everybody else, from what our analysis to that point had shown us, was everybody else would have a ceiling effect on the upper extremity motor score. So that shows you that only 61% of those 89 people could be enrolled in a study. That's 54 out of 84. But if you look at GRASSP strength, which has a much broader range of measurements and is scored out of 100, you can go up to almost 90 on the GRASSP before you are going to hit a ceiling effect. So if you take that extrapolation, so what we've done over here is we've shown you what, in this red group, we've shown you what people between, I think it's 31 and 93 on the GRASP at 6 months, what their upper extremity motor scores were at baseline, and it's 29 to 46. So what we're saying is that you could potentially take people with an upper extremity motor score of up to 46 at baseline, and you will likely see change on every single one of those patients if you use the GRASP to assess their strength at endpoint. So we have an opportunity here to use what we have in this field now and to make our trials more inclusive. By making our trials more inclusive, we can do our studies faster. So enrolling 54 patients versus 84 makes, 54 out of our 89 people versus 84 out of our 89 people makes it a lot faster for us to be able to complete these studies. So that's a great opportunity that we've come through to. And that, in fact, is what they did in the NISCI trial. They actually enrolled everybody because they have these, they used more sensitive tools so that they would look for, they were able to find anybody that was having a ceiling effect and eliminate them with more ease. So I'm going to share some bits of data from the NISCI trial, which was done in Europe and just closed last, I'd say 2024. And 2025, they've started releasing some of the results. I'm going to share some of the GRASP outcome with you. I'm going to only share with you the motor incomplete data so that we can talk a little bit more specifically about opportunities. Do you guys see my slides again?
We don't see your slides online. No, there we do now.
Okay, great. So this study was done over the course of 2 or 3 years. We had, I made an error. Every individual is assessed 4 times. And the placebo number is the number of assessments, not the number of individuals. I want to say it's somewhere in the neighborhood of 40 something. And similarly, the treatment group, I've got 324 occurrences. So please just divide the number by 4. My apologies. It gets about 70 or 80 patients. And of course, they did a trial where they were, I think, 2 to 1 for one placebo for every 2 patients that were treated. And if you look at the longitudinal profile, you can see, not in this room because of but you can see that the treatment group far exceeded in strength, SCIM, SCIM total, and SCIM self-care benefit from getting the drug. And I'll share that with you in just frank numbers so you can actually see it. I'm sorry? No, it's fine. I think it's fine. If you can.
On the recording is clean.
Okay.
So
all right.
Everyone have a clean.
Okay. And if you look at the differences, we do see that the difference between the treatment group and the placebo group across the board, SCIM, GRASP strength, GRASP upper extremity motor total, etc. Everything is significantly larger. So there's significance in all the differences. So we saw that over 6 months, if you treat people with ASIA C and D, which is a novel approach because we haven't treated ASIA Cs and Ds from baseline or from early after injury with a drug ever. Actually, this was the first time that they do remarkably well. So that tells us that if there's retention of neural structure, there's still some pathway there that you can treat them and make them even better. So this is one way that we look at some of the data. So what we did was, so people will say, oh, great, there's a score, it's better. But are they better? Are they really functionally better? Are they doing more? Can they do more? So we took an approach of looking at non-functional muscle. So non-functional muscle activity, which we said was 0 to 2. And do they convert, or does that muscle convert to a grade 3 or 5, grade 3 to 5? Because that really tells us if they've gone from being able to perform a task against gravity versus just having movement or activity. And so what we saw is red is the treatment group, blue is the control group. And if we look at it across the board, the percentage of muscles that go from 0 to 2 into the 3 to 5 range increases every single time with every measure we used, with every combination of muscles we used. And we did actually see, and this is where we see the difference between GRASSP and upper extremity motor score, that 24% of the muscles that are additional to INSCI actually convert. So what we're seeing is that if we look at muscles that aren't typically selected, the muscles that we don't call the key muscle groups or key myotomes, if we look at those muscles, that's where we actually see a lot of the change. Hence, possibly why we've missed change in the past. So these are great ways to think about what assessments are you going to use? How are you going to measure these people? What are some of the endpoints you can design in studies? And can we now design studies for people that are incomplete? And the answer is yes. So this is a categorization that the EMSCI group has done. And I just want to bring your attention. This is SCIM self-care, which is out of 20. And I want to bring your attention to the bottom row where we say that if they're in the 16 to 20 range, you've really hit the nail on the head by getting them to be independent or functional with their upper extremities. So they took this paradigm and they applied it to their sample. And basically what they found was, and so in some studies and in some environments, people are thinking about using SCIM self-care as a primary endpoint, which is a big shift, big change in perspective. But what they were able to show is that 20% of the control group were able to enter 16 to 20 range, but 45% of the treatment group was. So that's a really big difference when we think about function. A lot of us are clinicians in the room. It's a big difference because this is going to change how much assistance they need, how much support they need in their home, and essentially the economics are much better here. So this is just, like I said, a small little tidbit. So we wanted to look at, we've gone from not really studying cervical patients, now moving into this generation of assessing people with cervical injury, trying to understand what are some of the targets for treatment and intervention and where should we be going. So now that we have some of these studies done and some of this data, we can start to look at is it sharing again? Okay. We can start to look at some concepts around what do we treat? What should we target? So I know that holistically, we always treat the whole patient. And sorry, this is really, oh, can you see this? You guys can see this in this room, right? Oh, it's just you. So we took a machine learning approach to some of our historical data that we had. So we had a cross-sectional data set and we had a longitudinal data set. And we looked at, well, what this is basically in a nutshell, and even for me to explain exactly what was done here is not possible because I am a clinician. But what it tells us is these are the muscles that will predict those people getting into the 16 to 20 range. So the muscles, so starting from the top and moving down, this is the significance of which muscles are helping that individual or those individuals get into that 16 to 20 range. So you can see that in our cross-sectional group, as a one-time point, you've got extensor digitorum is a very important muscle to try and restore or regain function in. And on the other side, similarly, first dorsal interosseous, extensor digitorum. So here we were able to sort of develop this model. And then we took this model that we developed on our historical data set and we applied it to the INSCI intervention. Because we were asking the question, why did so many people make it into that 16 to 20 range of the SCIM self-care? So what we found is with the treatment group, of course, the two of the top muscles were, so there's hand intrinsics, which are important, but one of the really big ones, I didn't bring a pointer, my apologies, is elbow extensors. So when you're thinking about what is it that we're restoring, are we restoring arm extension? Are we able to get that reach? So I know historically clinicians have said this for years. We've talked about it for years, but now we have some true evidence to say, yes, reach, extension of that arm, and a little bit of hand intrinsics is going to change everything for a patient. So now we have evidence to show that we can actually also treat these elements of the hand. So with the NISCI trial, I think it's one of the first trials that we've really seen the intrinsics of the hands be targeted with a drug early on. We typically don't see that. We see the larger muscles really benefit, but we haven't seen the hand muscles transition as much as we have in the past. So those are some of the little snippets from the NISCI trial that are telling us, you know, who should we treat? How should we run our trials? When should we deliver treatment? And now we are making an impact on the hand, which, like I said, it hasn't happened so successfully. So I'm not going to go over the details of the Onward trial. I just want to say two points. So this is a fantastic trial in the field simply because it's brought the opportunity for us to do something for the population of people with spinal cord injury, predominantly motor incomplete, a new intervention, a new opportunity to enhance their function. But one of the more significant issues that is raised in the study is we see that when you're just looking at the three or even just one, the one table, the QT table here towards the right of the screen, what we're looking at is the increase in gray with exercise alone, and then the increase with stimulation added. In all measures and in all cases, we saw an increase with exercise only, and then adding the stimulation also enhanced that increase. However, not necessarily did it increase the change exponentially or double or triple. It was the same trajectory of improvement with the stimulation. And that's what we're seeing in a number of studies. So I'm a physiotherapist, and this is what I want to tell you. Okay, so there's lots of great stuff. There's drugs, there's stimulation, there's you name it. But this is what's done in every single study, and in every single study, this is what makes the change first. Okay, so always remember that. It's not a magic bullet. It's not a magic bullet. It's us. It's clinicians, it's physios, it's OTs. It's what we do with our patients that has a massive impact on the change, and even chronic. So all of these patients were well over a year post injury. So we did a similar study. We did a much smaller study where we looked at activity-based therapy and transcutaneous spinal cord stimulation here at KITE. We activity only, then we added stimulation, and we had similar results in the sense where I won't go into too much detail. I will share my screen again. Is it there? Okay. We essentially did an activity-based approach of exercise, which was different than the Onward trial. And we applied as similar as possible. We used the Mind Search to deliver a pulse width of approximately 1,030 hertz to the cervical spinal cord injury. We used 2 electrodes. We had a sample of 11 patients, one which dropped out before stimulation started, and patient number 9, maybe it's number 8, was not a true spinal cord injury, sorry, it's surgery. And our findings showed us that, again, patients did great with exercise. They made significant gain, and then post-stim also had about the same gain. So this is using the GRASSP as a total here. We do have, more, we have smaller elements of the GRASSP that we've analyzed and we're currently putting together for publication. But the point I would like to make is, yes, exercise helps, and yes, adding stimulation helps, but not necessarily is one superior over the other. And this is just to show you here very briefly that not only did we see clinical improvements, we saw improvement in their electrophysiology testing. This I would credit Shirin Tajali with this slide, where she was able to determine that particularly extensor digitorum, and I think it was triceps, both had significant improvement in the size of spinal motor evoked potential. So the evoked potential was stronger after the intervention in those 2 muscles in particular. So that's a little tidbit of the study we did here. There's a lot more to share around it. I just want to give you you know, the tip. So the tip is that exercise works, stimulation works. We need to refine what we do to see how we're going to make or have even better results. And a lot of that has to do with customization. And maybe the stimulation needs to be customized for each individual as well as the exercise. And then perhaps we might see these larger changes. And then I just want to touch on this because most of the research and the work that I showed you in the first 3 studies is basically saying that, you know, when you're motor incomplete, you're going to make gains and you're going to have benefit. And a lot of things don't work as well on our motor complete population. So they usually do more poorly in the drug trials. They've done more poorly in the stimulation studies and so on and so forth. However, what we are seeing is, and with evidence now, that if you consider our motor incomplete group, so I don't have the N on this. This is a pan-Canadian study that's being done. And in fact, Toronto data is not incorporated into this as yet, but we will be joining this team. People that are motor incomplete, so they fall into the AB group, and pre-surgery, so the total GRASSP on one side of the hand is out of 116. And if they are about 6 months, a lot of them are at a baseline of 34. They're at a baseline of 34 in this study, and they basically top out at 2 years at 60. So they almost double in their sensory motor function on the GRASSP with a peripheral nerve transfer. If they don't have that peripheral nerve transfer, our historical data shows you that they hover at between 40 and 45 if we take the median of where they end up at 6 months to a year. So the opportunity for motor complete patients after 3 to 4 months really does become peripheral nerve transfer for functional gain at this point in time, or at least that's what our evidence is showing. And I do believe that some of these studies will become a little bit more robust in the next few years. We'll be able to see a little bit more granularity here. But that's it. As far as other types of treatment go, we don't see this much gain in the motor incomplete group. Sorry, motor complete group. We're not seeing the gains we're seeing in the motor incomplete groups. So my general topics, we've got this changing perspective of SCI trials that we've talked about. So like I said, we went from thoracic to cervical, from cervical acute only to cervical rehab, and we've really transitioned. We saw what the evolution of studying the upper limb is and where it's come from. You know, it's come from this concept where we had some interest in studying the upper limb from some of the basically patient-centered, if you may, I don't know the exact today's term, but the patient-centered or the stakeholder-centered research that was done that upper extremity is important first. Then we developed assessment tools that could do so. And many of our patients are cervical in nature. And what is it that we are able to offer our patients today? So we now know that there are definitely emerging opportunities for the motor incomplete group of people. And I mean, these opportunities are being studied on motor incomplete patients. Doesn't necessarily mean you can only apply them on motor incomplete. You could most definitely apply them on the whole cohort of people with spinal cord injury. However, we are seeing that if you're doing your studies on motor incomplete people, you're more likely to see the results you need to get FDA approval. And the moment you have FDA approval, you now have an opportunity for your patients. So if you're thinking in that way, that's potentially what can happen. We're seeing that if peripheral nerve transfer is becoming an option for motor complete patients, so it is more and more looking like people are making gains and they have an opportunity. But you did notice that it's a 2-year time frame that they're making that gain over. So not necessarily is that always somebody's preferred opportunity, because it's going to take approximately 2 years for them to make those significant gains. I think customization of intervention is a key element here. So we're starting to see that if we are really customizing the intervention, like I'm talking about the exercise therapy and the treatment, etc., that we're seeing some very key changes. But I think the actual drug itself, the actual device, the stimulation also needs to be customized for how an individual might respond to that intervention. Our important next step is combined trials. So make no mistake, we are already doing combinatorial treatments, if you may. We're doing exercise coupled with devices. We're not doing a lot of drug coupled with intervention. And I think that that is something that we really want to transition to as soon as possible. And of course, a lot of this knowledge, which is now out in the public domain, is an opportunity for us to improve access to intervention. So when we, for a long time, historically, we eliminated Asia Cs and Ds from trials. So now we've opened up that opportunity for a cohort of people with spinal cord injury. So I'm going to end with that, and I'd like to hear from actually all of you and your perspectives. I'd love to hear some questions and talk a little bit about what are your thoughts on where we're going and what are some of the things we need to be trying to do. Where should we be trying to take that next step further?
Yeah, so you take some questions in person. We'll also monitor the chat online as well. So, I can start us off.
Okay.
I was wondering, because I've seen this a couple times and I've never heard someone say this, like really talk about this distinction between A and B and C and B and kind of split the data, but I have seen it come up even with some vagus nerve stimulation stuff where we're seeing bigger gains in the incomplete spinal cord injury. But what I'm wondering is, are we ever looking at like relative changes in those two distinctions? Like obviously there's a bigger absolute change in the incompletes, but are we looking at the relative changes? And also, is there potentially like a different MCID for these two different subpopulations? Like is a smaller change in a complete injury still meaningful or as meaningful as the bigger changes in incomplete injury? And do we ever get that gauge? Are we asking people with complete injuries, even if they make a small change, is that something that's potentially just as meaningful, but we have one MCID across the board, so we can't catch that?
That's great. Okay, thanks. That's a really good question. So first of all, I didn't share the perspectives of the patients with our ABT study. So our 11 patients, the perspective is very different than the objective outcome. They were very satisfied with the intervention. They all felt that they made a gain. In some cases, they said, oh, my gain's modest. I haven't gained function, but I feel better. I like the way I can activate my biceps because it was flaccid before. So to answer your question, yes, and we still collect all of that information. So perspectives are really important. What the clinician thinks isn't nearly as important as what the patient thinks. And that is kind of the challenge you face with the FDA, because the FDA will say, well, unless a treatment gives somebody this large change, this MCID that's been established in some who knows where, unless they attain that MCID, your drug or your device is not approved, right? So that's the challenge. But yes, we do. We have lots of perspective. The second thing is MCID is established for GRASSP between motor complete and motor incomplete, because when you combine motor complete and motor incomplete data, but in my opinion, you really muddy the waters. You pretty much have the smaller gain cancel out the larger gain. So you really need to separate the groups, but this wasn't done for a long time. In fact, CDs weren't really studied that much, like not with an intervention. We did a lot of natural history on them and said, oh yeah, they all get better. A lot of them walk again, they do well. We didn't really treat them. We didn't really look for new interventions that would benefit them. So this is a big shift. Yeah, so we do, and are other people doing it? I do believe with SCIM, they've done it, and a few other measures. So, and the literature is available.
Thanks for the perspective.
Mhm.
Online.
I've got a question.
Alina's gonna be.
Great presentation. I think it's really interesting to see how the field has evolved in such a short period of time. I don't think I realized how recently a lot of these changes have been happening, and it seems like we're really in a period of innovation right now. So I was curious, from the perspective of upper extremity outcome measures, what do you feel like is missing, and what do you feel like should be coming next for researchers who are studying upper extremity outcome measures for people with spinal cord injury?
Wow, that's a good question, Lena. So what is missing? I can tell you. So there's a dance, right? There's a little bit of this dance that you do between a clinician and a patient or a consumer, what do we think is important for change? What do we think is an important change versus what do the regulatory bodies think are important changes? And that's what's driven a lot of how we do measurement and what we've decided to do for a study. But I think patient perspective is a really important element to determine whether people feel that it's important for us to invest in doing a treatment or invest in doing a study. So that's part of what's missing, and that is changing with the NASCIC group and bringing advocacy into study design and so on. So that's one piece, is bringing in the perspective of the person that's the end user. I also think that we need slightly even more sensitive tools for two things. One, for helping us determine who's going to be a responder. So EMG studies at the front end, a little bit of electrophysiology testing at the front end to tell us, is that neurological system intact? And if it is, can we tap into it? So I think that's one thing we need to establish, and maybe a standardized method, something that's clinically useful. So am I going to do FES on this muscle or not? You know, do they have a chance? Because we also have limited time, so we want to put our resources where we know we can give somebody the most, right? So I think investigations that are going to help us determine how that system's going to respond to an intervention. So I think that's probably one of the bigger missing gaps.
Thank you very much.
Well done, Sue. And I really appreciated the walk down memory lane. And it makes me realize like how long we've all been around this field. Not all of us, but some of us. My first question is, so I really appreciated you talking about the importance of harm extension in terms of recovery. In terms of the treatment paradigms, can you talk a little bit about how many treatment paradigms are including the reaching and not only the hand function piece?
What do you mean by treatment paradigm? Like what we did for treatment?
Just in general, because I think there are a lot of interventions that only treat the hand, but not treat the hand and the arm, and to include the the reaching piece of it.
Right. Okay. So I would say that when we did the Onward trial, they had 6 categories of exercises, and only one of them were large movements for the arm. And everything else was focused on the hand. You're absolutely right. But that's why we did the activity-based therapy study, where we did a lot of large movement treatment. So we did arm biking. So we did cardiovascular, we did arm bike. And then we did basically flexibility and strengthening of all the large muscles. So we did deltoid, bicep, tricep. We didn't do a lot of functional activities with that, but we did a lot of strengthening. So if it was just active assisted bicep curls, we were doing them. We really focused on the large muscles because the reach is really important. With some of the other studies, I can't say what they've done because they don't document their treatment, but you can see, this is where you see, like you saw triceps really made gains in our AVT study. The neuroplasticity was definitely there. We were able to restore triceps. So I think that just remembering, and that's why it's so useful to have done that research, is that if we give them back their hand and we don't give them back their elbow or their shoulder, we aren't necessarily going to have a functional individual. We're certainly going to have gains, right? But not a functional gain necessarily. And so it's really important to remind everybody, that table that John Steeves made many years ago about what level do you have, how many levels do you have to gain to be functional? Well, if you take these muscles and look at it, it's actually C7, right? It's C7. So if you can give somebody back C7, you actually bring them into 15 and above on the SCIM self-care. So now that we have these paradigms of measurement, we can target, we can sort of say, let's try and hit these targets when we do intervention. So yeah.
That's another question I thought of, unless you're wrong. Was your question online?
Yeah, why don't you guys, can you read the question?
Alina, can you read the question online?
I don't see any questions online.
Oh,
I
Anita,
think
you
it's
could
just
just
me telling
unmute.
people to Oh, sorry, the hand. Sorry, I thought you meant the chat. Anita, you can go ahead.
Hi, Sue. Great presentation. I think can you hear me?
Yes, I
You
can
can hear me. Okay. I think one of your most telling slides was the slide that you had, that you boxed in and said that therapy alone, intensive therapy alone, was just as impactful as stimulation. Like stimulation didn't add any additional benefit. It was more just along the same trajectory. And so I think my question is, how do we translate that to practice within our inpatient, outpatient settings to make sure that patients are getting that level of intensity of therapy that's going to make that difference? And can we start to look at setting up home programs? Because above and beyond, like in terms of therapy, like hand and arm function therapy is a very easy therapy to translate to a home program compared to things like
it
walking,
is.
function, and that sort of thing. So how do we start looking at creating models of care for increasing that therapy intensity, both inpatient, outpatient, and at home?
Okay, so the question I'm getting, you broke up a little bit, so I'm gonna repeat your question. Basically, if we're saying in some of the research that we're doing that intensification of therapy and even long-term, out long past the injury, is one of the most effective techniques, how do we translate that? Fair?
Yeah, that's true.
Okay. So there's some ideas, I'm a clinician and I actually have a few really, some ideas that could potentially foster that. But as you know, inside the public sector, and I do agree with you, it's really hard to translate upper extremity rehab into the home. Because if you are doing something with the person, when you're doing something with the person, you usually need a second person to help them get through an exercise. Even if they can do it completely on their own, you need to set it up or what have you. So you're right that it really needs to be done in an environment. I mean, we need upper extremity programs in our system, whether maybe they could be at Variety Village where we set up, upper extremity classes 3 times a week and they're run by, KINs, PTAs, supervised by a physiotherapist that prescribes the intervention, etc. But Heather, you have something?
Something I just wanted to say no, I think our clinical colleagues have just left. But I would say almost every patient is discharged with a home exercise program, both lower extremity and upper extremity. But what we see often when they return for outpatients, because there's often a delay, is a large number of patients who don't continue with their home exercise program for a number of reasons. I think that's one of the things we can and should target, is how to support people to do the exercise at home. Like I think we know some of the programs where people are coming back for exercise and interventions, but carrying that over in the house sometimes is hard. It's, you've just been discharged from hospital. There's so much going on.
Yeah.
But then when they finally get to outpatient, so they get to private therapy, they appreciate that time that was lost by not continuing the gains they made in inpatient. So what are the barriers to that and how do we support people, whether that's virtually, getting them into community? Across the board, the outpatient clinicians will always say there's so many people who just drop in terms of their intensity, even though the exercise prescriptions were provided. There's the people who will continue, like they're absolutely just as, keeping that intensity up, but there's a lot that are not.
So to add to that, thanks, Heather. I think it's really important for us to start to educate that the rehab doesn't end when you leave the rehab institution, and it's kind of the job of everybody. So it's not just the healthcare system or the rehab system that's got to come up with a solution. We as a community that are wanting people with a spinal cord injury to live better, live healthier, have to probably work together and come up with some strategies and ideas. And I know there are some places in Saskatchewan where they're working on the ABT gyms, these outpatient, and I really think that that's the direction you want to move in, and have different facilities and environments, where people can come or they can connect with to be supported for the program. And yes, yeah, I think we really need to start to push the agenda and maybe not spend so much time thinking, hey, what about this device? Because this is something we know how to do, and people are ready for it, so we can do it.
All right, it's 1 o'clock now. Unless there's any burning questions, everyone thanks Suk again for a wonderful talk. But yeah, thanks everyone.
Thanks for joining. Appreciate that. Yeah. Oh, that's fine. Do you have-
No, the people just me. And the turnout was really good, actually. It was like almost 40. I think it's 40 something online, and then over 10 in person.
Then he has in surplus.
One of the
Yeah,
bigger
But I
Juice
said,
lectures.
the trend,
I think
like,
you
you don't
did
want to abuse, so you let us know.
Yeah.
I think we're just talking.
Yeah.
I'm gonna leave. Okay.
Yeah, that's fine.
So that's why. So, anyway, I don't know.
Yeah.